Hello, this is Rick again, and in this video lecture, we're going to introduce you to more of the finer details about the HCC reimbursement model for Medicare Part C. And again, this came from a webinar that I attended last year with ERG, which is a consulting group, and they reach out to physician groups and others to educate people about HCCs. And they really do a nice job. And I like their material so much. I had a nice meeting with Cameron, who was agreeable to having me share it with all of you. And I'll be posting this on the learning management system on Moodle. So again, I just want to go to some of the highlights. So what HCC is basically changing the whole paradigm about how physicians and hospitals get reimbursed. And again, this goes for Medicare Part C primarily, although as Medicare sets the tone, other payers are jumping on. So the idea is that we're having value-based payments. So in other words, the purchaser of the healthcare services, in this case CMS, is going to be paying people for more efficient care, not just paying them because they're ordering more tests or seeing people more often. And you can read more about some of the finer details here. Risk adjusted is a common insurance term, which means there's an actuarial calculation used to predict healthcare cost. Risk adjustment is the mechanism for adjusting the payment rates or budgets or both, right? And you see a lot of this, and we'll be seeing more and more. This model of Medicare reimbursement came into being in 2004, and as it stands right now, based on the latest information I can find, the state of Oregon has 35% of its Medicare patients covered under some sort of Part C plan. And you can see some of the differences here. You get an annual capitated payment based on your risk-adjusted scores, right? There's some bundled payments, which I'm not really going to focus on. But this is somewhat different than the whole model. And all these things about the bundled payments, pay for performance, the ACO shared savings, the medical homes, these are kind of going all in the same direction, where it's value-based payment per member. This is different. This is kind of the old model that we all had. We're seen in the doctor's office. We have a visit. It's coded with 99215, and there is the charge. Everybody understood that. Everything is good. But now the new way of thinking, particularly for Medicare Part C patients, is we have a score that includes some of the patient's demographics, how old they are, whether they're dual enrolled in Medicare and Medicaid, what have you, and then the health status. This relies on accurate documentation and accurate ICD-10 coding. And then we come up with a risk-adjusted score, right? We used to train physicians on this at Kaiser, and we used to say your typical Medicare patient had a score of 1, and then the more chronic conditions that are captured, coded, and addressed, meaning we don't just pull them off the problem list and stick them in there, but we're actually referring them or managing their meds or ordering tests or what have you, that affects the risk-adjusted score. What's happening here is these mappings that you'll see in an example later on change from time to time. For instance, you used to be able to get reimbursed for an old MI. Now you don't, right? And there are other things, and these are updated every fiscal year by CMS. And as we mentioned, this is usually released in the spring, so it'll be coming up for the next calendar year. You can click on this link if you want to see the announcement for this current fiscal year. We're going to a new set of Medicare Advantage HCCs that you'll be hearing more about, but the premise is basically the same. So with these new sets, right, for calendar year 2024, they're going to be using a hybrid model. And then over time, by 2026, we'll be entirely on the new model. Let me pass over this. And again, you can see here, right, CMS is continuing the policy to calculate the risk score based on the payment to Medicare Advantage organizations using only risk-adjusted eligible diagnoses from encounter data and FSS claims. So what does this mean? What this means is you get paid, condition has to be documented, captured, and addressed once a year, and it has to map back to one of those HCCs. And again, these are updated and variation on the risk scores, right? And the beneficiary risk score may change depending on an individual beneficiary's combination of diagnoses or the clinical plan of the plan's enrollee population. We talked about some of the demographic factors that influence the risk score. This includes age, sex, whether somebody's dual enrolled, a new enrollee, continuing enrollee, and all these different types of things. And V28 is what we're moving to, right? You can see the HCC categories here. HCC1, dealing with HIV and AIDS, maps to ICD-10 code B20, and so on. And you can see all these, right? A lot of these stay the same, and some of these change. For instance, HCC 18 was metastatic cancer. Formerly, it was HCC 10. And you can see some other ones here. Something that also is being put here is that some HCCs interact with each other. For instance, congestive heart failure and diabetes, congestive heart failure and COPD. And so basically they give additional coefficients or weight to kind of offset any additional cost of managing these two chronic conditions. The older version of the HCC reimbursement was V28, right, which had all these different changes. We're now moving to this one, which is V28, and you can see some of these things and their coefficients here. And again, here talking about the coding pattern and adjustment, this is getting a little bit beyond what's probably appropriate for this course. You could teach a year's worth of college coursework on this. But the important thing is to realize that it's an entirely different model of reimbursement. One last thing before I close here is there are different benchmarks. So if you go to this link here, you can get an idea of how they can adjust this thing. Note that certain places like Los Angeles are going to be higher than, say, Cook County, Chicago, right? And so on. And that's all I have for you. We'll see you online. Bye now.